Hello, this is your brain on drugs, and this is a punk rock psychiatrist. So today, I think I'm going to break up this next topic into two different episodes. Um, there's quite a bit of material to get through here, and I think this is going to be really, really interesting. This is something I've been looking into more over the last year. So what we're talking about is the effectiveness of antidepressants. So in the first episode, part one, we're going to talk about just the general effectiveness of antidepressants, how that's kind of happening, how you might be able to alter that, and things like that. And then in part two, I want to go into more depth about the relationships with the patient, kind of using kind of therapeutic psychodynamic techniques that may influence how we can prescribe and do it in a better way. And I have to admit, I this is not my cup of tea. I think a lot of people go into psychiatry because they have this kind of style, this good ability to make relationships with patients and get good therapeutic alliance. And I think we think of psychiatrists as maybe the ones that should be or are the best at this of the different medical professions, and that definitely is not me. I found myself into this profession and wasn't quite sure what drew me to it. Wasn't quite sure what it was that I was gonna look at excelling at, and I think I struggled a lot as an intern. I struggled a lot with exactly what we're going to be talking about in these two episodes, and that's how to interact with the patient to improve effectiveness. And I guess I thought, well, if I'm not prescribing meds, then I really need to worry about this stuff. And if I am prescribing meds, I don't need to worry about it as much. I can just talk to the patient, get their history, ask them some questions, assess, diagnose, come up with a treatment, discuss it with them, and do the treatment. And a lot of my colleagues, they really wanted to do more of the therapeutic things. And the program that I was a part of, they that was a big part of how they taught it. Was they were trying to make the psychodynamic piece a big part, and we had to get supervision for 2 years. Do I'd have at least two different patients and do each one for a year and get psychodynamic supervision for that whole time. And to be honest with you, I hated it. It was my least favorite part of training. I found it to be the most difficult to kind of pin down. In school, I was a math science guy and I was not a literature kind of person. And so I think I like I like facts, I like certainty, I like statistics, I like numbers. I like to know that there's an answer. And I think that's why I gravitated to the chemical side of things and just kind of looking into the chemistry and how do these drugs work and how can I, pick the best one and, help patients the most with the drug that I'm picking. And maybe going into psychiatry was not the best plan, if that's my strength. I think you having that more abstract or like complicated thought process to work through things with patients. And um, I had a staff when I was a resident, and he was excellent at kind of. I had a couple actually. There's a couple that I remember. They were very good at reading the patients and saying the right things to the patients at the right time, and it really made a huge difference. And I would read their write-ups, and I would be like, wow, they really understood the psychology of that patient. And I was more of a nuts and bolts, just what's true, what's false, what do they have, what do they not have, what chemical part of their brain am I trying to interact with. And so I think that's something that I personally could benefit a lot from improving on. But on the other hand, it's not really a strength of mine. You know, Interacting with people and engaging people and, being this schmoozy, likable person, extroverty, knowing how to get the best out of people, that's not really my strength. My strength is statistical type of things. And so that's why I'm teaching um, this podcast the way I'm teaching it. And it's why I was happy to teach the pharmacology of these drugs to residents, because that's really my strength. And unfortunately, as I've mentioned before, the drugs, especially when we're talking about depression, that's not the biggest piece of what's going to help the patient. Maybe I should have gone into a different field where the treatments that we give to the patients are much more effective, and they're much there's much more weight behind that. So I really like that chemistry a lot better. So what I but what I want to do is I do want to address this topic, and I want to give as much education and information as I can to you all, even though this isn't my strength, because I do recognize it as maybe the most critical thing that you could master, especially when you're treating the more, less severely mentally ill patients with mild to moderate symptoms of depression, mild to moderate symptoms of anxiety. So, with that, let's dig in. I want to start off kind of talking about like the what effect size is. All right, so effect size, it's a formula. Sometimes it's called like a Cohen's d. There's different names for it. It's a calculation that involves the difference between placebo response and response to the drug, and standard deviation, and it's put into a formula, and it spits out a coefficient. So basically, a number that has no units, right? So it's just a number that we kind of arbitrarily kind of come up with this equation, and then we've kind of drawn these lines to say, this number indicates this much effectiveness, and this number indicates this much effectiveness. And I think a really good research paper is going to give you this information. Now, some of them might call it a Cohen's d, some might call it effect size, but some don't recognize it at all. And to me, that's problematic. Like, I don't know how much I can judge how good a treatment is, because if basically all studies are basically trying to show you statistical significance. I've talked about this before, where statistical significance is just that there is a statistical difference between, you know, say drug and placebo, between, the two things we're measuring, which is often drug and placebo, or it might be a drug against another drug, or a dose of drug versus the dose, a different dose of that drug. So you're comparing things, right? And if, you run all these numbers and you get the correct power, and it depends on how many participants there are in the study, and how much difference there is between the values and the averages between different patients. And you get your p value, you want to be really low, and you want your confidence interval to be, to not cross over the into like the you don't want you want your confidence interval to not contain basically that there was no result. So that's how you get statistical significance. And I was just looking at a study the other day. I think it was on iloperidone. Iloperidone this year, it was, or maybe it was last year, was recently given approval for use in mania, in bipolar disorder one, a mania mixed episode. I think mania mixed, or mania in bipolar one. And there's all this fanfare, like, oh, we've got another treatment, and it's like, we've got like 8 antipsychotics that we already have that are approved for this. um how amazing could this possibly be? Like, do we, I mean, I'm assuming that all these antipsychotics work in a very, very, similar fashion. They're probably all going to be fairly effective. If one's effective, another one's probably going to be effective, right? And when you look at the study, I think the scale, the what is it, young mania rating scale that they used often to rate mania, manic symptoms, it fell by 14 with iloperidone and 10 with placebo. And I'm thinking, 4 point difference, it's pretty crappy. I mean, a 14-point difference is huge, right? And remember, and that's the other thing to think of it. Wow, most of the effect is placebo, right? most of the, I mean, for a 14-point drop in and of itself, compared to, I guess, if you gave no treatment, perhaps, would be pretty remarkable. But like versus placebo, a 4-point difference on this scale, it, it's statistically significant, but is it clinically significant? Right. And I've talked about this idea. So statistically is, using the statistics, and we've defined what, that there's a difference between these two things. You could have a point 0.1 difference on a 50-point scale and have that be statistically significant. Like, oh, we definitely know there's a point 0.1 difference because of we have such a huge power and so many participants, right? But is anyone going to feel like a point 0.1 difference on a 50-point scale? No, they're not. Are they going to feel a 4-point difference? Probably not, right? So the effect size in that study was actually only zero point 0.2, which is a pretty low effect size. It kind of says to me that, point two, 0 means no effect. So point 0.2 means, yeah, there was an effect, but probably not enough for the patient to recognize it. So is this something I'm going to do? Probably not. All right. So let's talk about effect sizes. All right. So as I said, 0 is basically like no effect. Okay. So a 0 to 0.25 is considered 0 to small effect. And remember, the iloperidone study was zero point 0.2. So less than 0.25 is basically considered, nothing. Okay. 0.25 to zero point 0.5 is considered a mild effect. Uh, a zero point 0.5 to a 1.0 is moderate to large benefit, and over 1.0 is considered a very large, huge benefit. Okay. And generally, more than zero point 0.5 is considered clinically meaningful benefit. I've heard that as low as zero point 0.3, but generally we want at least zero point 0.5 before we're really noticing a clinical benefit. Okay? So explain to you what the effect size is, kind of how it was put together, and how effect size is more measuring clinical benefit. I mean, it's measuring the difference, but then we've kind of tagged like what range we are assigning to each one of these. Okay, so we generally want more than zero point 0.5 to kind of think that this treatment that we're giving them, and it doesn't have to be a drug, it could be any kind of treatment, that this treatment is clinically meaningful for the patient. All right, so let's go through the effect sizes of all the medications that we've talked about. And why don't we go ahead and start with the least? Now, the one at the bottom I have is actually not approved in this country, but it was in the study that I got this from a study called The Comparative Efficacy and Acceptability of 21 Antidepressant Drugs for the Acute Treatment of Adults with Major Depressive Disorder, Systematic Review and Network Meta-Analysis from the Lancet 2018, if you want to look it up, but you can also find these references on my slides. So at the bottom is reboxetine, 0.19, 0.19. So we're below 0.25 here. So we're really kind of like, yeah, not really clinically meaningful at all. All right. Antipsychotics, 0.2. Now I mentioned iloperidone 0.2. That was for mania, but this is for antipsychotic use in depression. We haven't talked about that yet, but we're going to get to that. But point two, not great. And these drugs have a lot of side effects. So a lot of side effects, only 0.2 effect size. Eh, I'm not feeling, I really don't buy into the antipsychotics too much for depression. I know it's done commonly and I've heard people say that it has great results. But I gotta say, I think it's probably mostly placebo. And this is what we're going to talk about in these two episodes. We're going to be talking about placebo and how to maximize it. All right. Next, we have citalopram and escitalopram coming in at 0.21, bupropion 0.22, desvenlafaxine 0.25, 0.24, and agomelatine. Remember, that's actually, we're trying to get that approved right now. 0.25. Okay, so there's our 0.25s and below. And oh my gosh, lo and behold, two of my favorite drugs are in there. Escitalopram at 0.21 and bupropion at 0.22. How could two of my favorite medications for depression have such a low effect size? Well, stay tuned. All right, stay tuned. Um, they're all pretty low. All right, they are all pretty low. And remember, the reason why I like those two is because they have lower side effects. And often having lower side effects means they have less positive effect, because I think part of the placebo is just that, you feel that it's doing something, even if it's something you don't like, and then you think it's, actually doing something good too. But anyway, pretty low effect sizes. Let's move up into the 0.25 to zero point 0.5 area where I had previously said that you're going to find mild benefit, right? So far, we're just kind of no benefit really. All right. So at 0.25 or zero point 0.26, vilazodone, we've got levomilnacipran at 0.27, sertraline 0.28, milnacipran 0.3, fluoxetine 0.3, paroxetine 0.3, vortioxetine 0.31, nefazodone 0.31, clomipramine 0.33, venlafaxine 0.34, mirtazapine 0.37, trazodone 0.38, duloxetine 0.38, fluvoxamine 0.44. All right. So we've got most of our meds have come in at this point. You'll see my hated venlafaxine is 0.34, and you're like, haha, venlafaxine beat bupropion and escitalopram. But really, the difference between 0.34 and 0.22 and 21 is pretty small difference. And as you'll also see, duloxetine came in at 0.38, and it's better tolerated and more effective than venlafaxine, although once again negligible. But that was one of my other A tiers if you listen to the last episode. And then I think, kind of shockingly, trazodone a little bit higher. I talked to, I've been thinking a lot more of using trazodone not just as a sleep med, but as a medication for depression, especially if we are only dosing it once a day. Um, that even those low doses, as we talked about in the trazodone episode, do have significant impact on the monoamines. And then we got mirtazapine, another one. I think I put that in my B tier. Um, if we can get over the weight issue, if that's not an issue, it's actually a fairly decent medication that's tolerated in many other ways. So another med that I'm a fan of, but still, I mean, we're talking about mild benefit here. Let's keep going. What meds, what treatments do we have that have a moderate to large benefit? 0.5 to 1.0. All right, we've got amitriptyline at 0.62, S-ketamine at 0.7, ketamine at 0.9. All right, now we're getting somewhere. I've heard maybe these amitriptyline 0.62 may be a little bit inflated because most of the studies done on it are a really long time ago, and it's hard to compare studies done decades ago with studies done today on more recent meds. And so that 0.62 actually may be a bit higher than in reality. I mean, when you look at clomipramine down at 0.33, I really don't think amitriptyline is twice as effective as clomipramine. They're fairly similar medications. But we do see, remember, I was a fan of ketamine at 0.9, and then S-ketamine I liked less well because it wasn't as good as ketamine. It costs a fortune, and it's a lot harder to get it prescribed, and it's lower effect size, 0.7. But both of those actually a pretty good effect size. I mean, I wish I had dextromethorphan bupropion on this list. Um, I'm not sure what the effect size of that is. I don't think I mentioned it in the lecture. I'm not sure if there are any studies that report that information, which is also somewhat troubling if that's the case, when they're just trying to get this approved and they're not reporting effect size. So, and then we've got a couple things that are above this. They're not drugs. We've got TMS, transcranial magnetic stimulation, at 1.3, and we've got ECT at 2.1. 2.1, that's massive. We're going to talk about ECT a little bit later, electroconvulsive therapy. I think a lot of people may not think about this, but it's actually one of the most commonly done procedures in the country. And it's a lot, I guess, I think it's a little more available than people may think it is, and it's tremendously more effective. I mean, we're at 2.1 compared to our average antidepressant is coming in, I'd say, around 0.3. Okay. And so the only treatments on this list that even fall into remember, the above zero point 0.5 clinically meaningful benefit are ECT, TMS, ketamine, S-ketamine, and amitriptyline is kind of questionable. It's also not very well tolerated. a very, anticholinergic, sedative, dizziness, just not great for all those reasons. Um, I would say that ketamine, ECT, and TMS are probably a lot, even though they're the three most effective treatments, they actually probably have a lot less side effects than a lot of these other treatments. So that doesn't speak too well to our meds, does it? Those effect sizes are pretty poor. When you look at methylphenidate and dextroamphetamine, mixed amphetamine salts, the stimulants we use for ADHD, they're coming in at like above 1.0 for treatment of ADHD. So um, these, like I said, these antidepressants, not that great at treating depression, not that great. However, the story continues. Let's talk a little bit more about the effectiveness of antidepressants. So, first of all, 12% of Americans are on them. That's quite a lot. All right. That's what? And is that an eighth? Or is that, I think it's an eighth, right? 12.5 would be an eighth. So about one in eight. And women over the age of 40, 25%. Wow. That's a lot. A lot of people are on these meds. Okay. 80% of psychiatric medications are given by primary care. Okay. So if you're not primary care, your mental health and your nurse NP, um, psych MP, nurse, or psychiatrist, you're only prescribing 20% of the antidepressants. The vast majority of them are given by primary care. So hands off to primary care for taking the load up on that. Um, the problem here, though, is that primary care doesn't have a lot of time and they don't have a lot of knowledge on these meds. And, I've noticed that they love to send these patients to me. In the military, um, I would say we had kind of a lot of psychiatrists um, based on the population that we served. And so pretty much anyone who had an issue came and saw a psychiatrist. And only a handful were handled by primary care. So in the military, I don't have figures on this, but I would guess that way less than 80% of patients were handled by primary care. I would say it's probably less than 50. So I saw a lot more. And I always appreciated that primary care was doing this because it gave me time to focus on the sicker patients, the ones that maybe needed a little more attention, were a little bit more challenging to manage, etc. But there are some other drawbacks to the care that primary care is able to provide with their limited um, time and knowledge in this field. And so what often happens is, because of those barriers, or those restrictions, um, they often will give the medication after a very short appointment. So they haven't really fully assessed. Maybe it's something else. Maybe something else is going on. They haven't really had time, and so they assess, and it's like, oh, this person's depressed, anxious. I'm going to give them this med, okay? And then often the symptoms are due to a transient situation, and they just haven't had the time to assess that. Like, I'm given a lot more time to assess the patients, and so I'll say, why don't we give this more time? Why don't we try therapy? Why don't we hold off on meds and kind of see if things improve? This seems like maybe an adjustment type of situation. I'm not sure that medication is the best treatment for what's going on. Maybe you should talk to your pastor, or, one of millions of other resources that we may have. But when they go to primary care, it's like, oh my gosh, I need to give them something. And this is the tool I have. This is the easiest, fastest thing. And maybe we don't have a lot of this other stuff available. I'm not familiar with it. And they just are given a med. And then what happens is they'll get a positive effect from the med, but it may actually just be that time passed and they got better, but they'll think that the med was actually the reason why, and then they'll end up staying on it for an indefinite period of time. And so now we've got them with this medicine in their system that they think, may be helping them, but really it was just, you know, things just kind of resolved with time. But now they're kind of in some ways like mentally dependent on it. Like, oh my gosh, I need this. This is what helped me, or whatever. And so that's not a great situation to be in. Okay. So There's actually little to no benefit beyond placebo for mild to moderate depression, adjustment disorder, personality disorders, things like that. As I mentioned, you saw the effect sizes. They're pretty low. In fact, I've seen a lot of guidelines that say for mild to moderate symptoms, they don't even recommend giving these medications. It's only for severe. Okay. So, and I think, a lot of times patients, they come in wanting some kind of treatment. And even if their symptoms are mild to moderate, like they're kind of insistent on something and like, what else are we going to give them? And then they get a med. And then, did it really help? And what's probably more likely to work, time. So just, time heals all wounds kind of thing. Like maybe with time, whatever thing is aggravating their symptoms is going to resolve. Exercise, diet, so like lifestyle type of stuff. If they just change their do some cognitive behavioral type of stuff, just change their behaviors, change their thought process a little bit, become more active, maybe engage with friends and family a little bit more, get better sleep, uh, eat a little bit healthier, things like that, and then therapy. So for these mild to moderate symptoms, we're really looking at therapy. And I remember when I was a medical student, um, and I saw this 60 Minutes broadcast, and there was this doctor on there that basically said, antidepressants don't work. And it was, for mild, they don't work. For moderate, they probably don't work. And for severe, they work a little bit. And I think there was a lot of backlash to that. It was like, oh no, our meds do work, but they do. But as you can see, the effect size is quite low. And we're going to talk a little bit as we go on why we may be seeing that they work a little bit better than they actually do. Like I said, it might be time, changes in behavior, therapeutic things, but also the placebo effect, which I'm going to get into. All right. And so, yeah, they're most effective for severe depression. And really, I try not to give them to patients that, if they've got anxiety, the anxiety may be a good indication. I don't know that the delineation has been made between mild, moderate, severe anxiety as it has with depression, where we say these only work in severe depression. So if I've got an anxiety patient, and a lot of time you are looking to give that placebo, okay? And like I said, that's what we're going to be discussing. Like, maybe the med's not doing that much, but how can we use the placebo of the med to our best benefit? All right. So let's talk about placebo. All right. Placebo effects. Now, studies have suggested that around 75 to 80% of an antidepressant effect is placebo. I'm going to repeat that. 75 to 80% of the positive effect that a patient gets that when they take an antidepressant is from the placebo. All right. Now, I think a lot of people, they think placebo is like nothing. It's like no effect. It's like, oh, it's this is like just all in your head and stuff, and this is not a real deal. But no, no, no. Placebo is, these are real effects, but they have nothing to do with the mechanism of action of the drug. They have nothing to do with what the drug is doing in your system. It's purely, I have a pill, somebody gave it to me, I put it I put it in my mouth and swallowed it, or whatever kind of treatment it is. Like I got a treatment from an expert and I took the treatment, and that's what the placebo is derived from. Now, remember I talked about the effect sizes for the meds. They range from like zero point 0.2 to point what 4 or 5 ish for the most commonly, right? We've got, what do we got? Escitalopram's kind of at the bottom, 0.21, and then we've got fluvoxamine at 0.44, and then the treatments above that are like more like procedures and ketamines and things like that. So we're really looking at a range of 0.21 to 44, and I kind of question fluvoxamine at 0.44, to be honest. It's a little bit above kind of the other ones, but kind of the 0.2 to zero point 0.4 range. Um, but what do you think the placebo effect is? What's the effect size of the placebo effect? This is something I think people don't think about. 1.59. Yeah, that's right. 1 point, remember above point 0.5 is clinically meaningful. Above 1 is a huge benefit. 1.59 effect size for placebo. That's a massive effect size. That beats TMS at 1.3. It's not as high as ECT. And remember, ECT's, the thing is, those effect sizes, so that 0.21 effect size by citalopram, you have to add the 1.59 effect size um, from the placebo on that. So your full effect of actually taking it is 1.8, right? And I guess with ECT, you got 2.1 plus 1.59. That's, what, 3.60, right? Right. 3.69, right? I mean, that's huge, right? You're getting the placebo effect and you're getting this effect, and with the drugs, it's not really adding much to the party, but like with ECT or TMS, you're getting the placebo and you're getting this massive effect size. So 1.59. And remember, I think I don't know if I've told this story before. When I was a med student and I was in a community, I was in my community mental health. I was in a doc's office, psychiatrist, and I brought up that 60 minutes thing to him, and he says, if you don't come see me, you don't get the placebo. And I was like, I like that. He's not out there defending the meds. He's not out there saying, no, these meds work. These are great. He was like, well, you're not going to get that 1.59 if you don't come see me either, right? You have to. So that's why I say, even though citalopram and bupropions effect sizes are quite low, they're not that much lower than anything else. And really, what we want is this massive placebo effect that you're not going to get if you don't take anything. And I'd rather the patient take something that has like the least amount of side effects, is the most tolerable for them, so we can get that placebo. All right. And the question is like, that's average. Not every doc gets the same placebo effect. And we're going to talk about that in the next episode. I'm going to go into the kind of the doctor patient dynamics and how, that affects how big that placebo effect is. All right. I think you're really going to enjoy that one. A lot of really interesting stuff. I'm sorry I'm not an expert on this topic, but I have done a lot of research and reading on it, and I put together these slides, and I think that you're really going to learn a lot. And maybe, like myself, recognize how you can make the biggest placebo effect that you can make. Because if you're just a crappy doc that doesn't care about his patients, or doesn't, is burned, we'll give you the benefit of the doubt, burned out, um, can't focus on anything, can't give the attention to the patients that they deserve, just going through the motions, you're just giving them like that 0.2, 0.3. You're not giving them much placebo. And they're probably getting a little bit placebo just for the act of taking it and maybe believing that it's working, but you're really not getting much out of it. But if you're like, really mastering the arts of the dynamics between you and the patients, you probably getting beyond 1.59. I mean, that's the average, right? So like, you could really get a huge placebo effect, right? And I mean, for someone like me that's like biologically and chemically minded and not so much psychologically minded, that's kind of a letdown. I pride myself in knowing everything there is to know about these drugs. And now I'm being told that no, you actually should be like a really good therapist, and that's actually, prescribing the drugs helps, that helps, give the placebo. That's part, they don't get they're not, the, when you look at the placebo from therapy, I think I only have a effect size for anxiety. It's around point 0.4 to point 0.5. So that's therapy, right? Still not this massive 1.59, right? So I think the act of giving the med, you're capable of gifting them with this huge placebo effect if you play your cards right. Okay? And that's something that just doing therapy may not do, because yeah, you're given the therapy, maybe therapy's a little bit more effective than meds, maybe not, maybe on average, maybe a little bit more, but you're not getting that same placebo from like giving the patient a medication that they're putting in their system. So if you can master both, and I think that's maybe what my program was trying to teach me. All right. So let's go into a little bit about how this placebo works, but I want to save most of this for the next episode. All right. So how you talk about the medications affects how they're going to help or harm the patient. All right. So let's take having an optimistic attitude towards medications. I remember I got a lot of stories. Hopefully these are illustrative for you. I was an intern on a cardiology rotation, and the cardiologist was, I was the psych intern, right? And we had a patient that, he thought could benefit, this cardiac condition, admitted to the hospital. We're rounding, he's like, why don't you go talk to this patient? And, and I was like, I don't know if this is really going to work based on what I've seen and stuff like that. And he's like, no, tell him it's going to work. Then it'll work. And like that concept to me was just like, but why would I lie? Like I know it's not that good, and especially like in this, I've assessed this patient, they're not someone I really think is going to respond to, but his thought was, have confidence that it's going to work. So we're talking about having an optimistic attitude towards medications. All right, now this can go one of two ways. Both he and I are correct. All right, so in drug naive patients, so these are patients that haven't taken these type of medications before, haven't been on antidepressants, they actually, if you have an optimistic attitude towards how well you think the medications are going to work, these drug naive patients are actually have improved outcomes with your enthusiasm. Okay, so that actually benefits them, right? If they've never taken these, heard of them, knew that they were out there, never tried them, and you're like, hey, these are great, they work great, it's maybe more likely to help that patient if you have that attitude. Now, on the flip side, if you've got a patient who's failed numerous meds, they often have worse outcomes if you have a positive attitude, because they're just like, who is this loser? Like, I know these meds don't work, and he's out here, she is like telling me, oh, they're great. These meds are awesome. I think it's really going to work for you. And I know they don't work. I've taken like 5 of them and they suck. Right. So basically, giving that positive attitude to that patient can be counteracted because they think that you're just full of it, right? So I think with these patients that have had multiple failed attempts, it's important to maintain a realistic humility about the limitations of medication. So these would be patients that you might want to be more like, these don't work for everyone. I understand that they haven't really been helpful for you, and I can't guarantee that what we're doing today is going to work. But what I'm going to do for you is I'm going to give you a med that's got a completely different mechanism of action. I think it it on average works a little bit better than some of the medications you've taken. So have kind of, give a positive um, attitude towards the med, but at the same time recognize that they've had the issues before and that they may not have the effect that we want to have. And just say, but we're not going to give up. We could also do like ECT or something like that. That's been shown to be extremely effective. Let's not give up just because you've had some failed attempts. You haven't done everything. All right. Just because what you've taken before hasn't worked doesn't mean that what we have that we have not given you won't work. All right. So I would give kind of more of that message, right? And you want to remind the patient that the medication is actually less likely to work if they don't commit to taking it. Like it, I don't, if I'm just forcing it down their throat and being like, no, 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 just try it. Come on. This is, and they're just like, I don't know. I just, nothing's ever really helped. I don't really want to. And, and I'm trying to, give that kind of positive attitude with limitations. I might remind that patient, hey, if you really don't think this is going to work and you don't like commit to like taking it as prescribed and giving it a shot and believing that it can work, it's going to be less likely to work. All right. And so I don't want us to waste our time with it necessarily if that's the attitude that you're going to have, because like I need you to take it as prescribed. I need you to think that this is like could potentially help. I need you to like be open-minded to that, because if you're not, it actually, these are patients I'll be completely upfront with. 80% of the effect is placebo, and if you have this approach, you're like lessening your own chances of placebo. And I know that it may seem like pointing that out would erase the effect. It doesn't. It doesn't. You actually can still get the placebo effect if you're fully aware that you're taking. They've even done studies where they gave people what they told them was a placebo, And those patients got better compared to people who took nothing. They're like, this is actually not a drug. This is just a placebo. And sometimes placebos work. And we're going to compare taking the placebo to taking nothing. Those patients still got better. And kind of a lot better than expected. Maybe not as much as if they thought that maybe they were taking the actual drug, but better than you would think. It wasn't just like a mild effect. So the placebo effect is, we don't fully understand it, and it's quite powerful. And if you can master it, you will be in a very effective provider. All right. So um, moving on to that point. So I talked about being optimistic. I want to also talk about educating of possible adverse effects. So this is another thing. There's some people like myself like to educate patients on all the possible adverse effects they may get, and some don't want to tell them about them because they don't want to implant thoughts in their head and give a nocebo. Remember, noci means pain, placebo means pleasure. So nocebo is, it may sound like no placebo, like no nocebo, no placebo, but it's noci. It's like a painful response. So you get, basically you get an adverse effect when it wasn't the mechanism of action that the drug caused, right? Instead of a placebo where you have a positive response that is outside of the mechanism of action of the drug, nocebo is you have a negative response, or an undesired response, we'll say. So some people think that if you, and this is true, both are true. All right. So most things in life, both things are true. Patients are more likely to get adverse effects if you tell them about adverse effects. However, patients are also more likely to continue the treatment if they get those effects, if you educated them about those effects. So I think you've got to kind of play your cards on this one. You've got to play a balancing act between not making it sound so horrible that they're just like really afraid of what's going to happen to them, while at the same time informing them. Okay, so you might say, patients will, I'd say about 20-30% of patients might get these GI side effects, talk about what they are, but say, that they typically go away. I'd like to, and that may make it more likely that this particular patient is going to get the GI or adverse effects than the ones I don't tell. But the ones I don't tell may get them and think they're having like an allergic reaction or something and stop taking the med and never come back and never find out like that's not actually, they didn't follow it. That's why I like to tell them up front. I like to be honest and clear that these risks are relatively low. If it is a higher risk, we're talking about Steven Johnson's from a lamotrigine. I'm not going to candy coat it and say, this is perfectly safe. I'll say, this is a very bad outcome that could happen. However, it's extremely unlikely if you follow the dosing guidelines that I'm suggesting. And if you notice any of these signs that you come in for medical care, the chances of you actually dying from this are almost zero. All right. You, there is a very slim chance that you will get Stevens-Johnson syndrome, but if caught early, the chances of death are virtually like not going to happen, right? I'm not going to say couldn't happen. I'm not going to say never. Never say never about anything, right? But if they're caught early, then and that's why we inform them, so that they know this is a possibility and that they can come in if they need to. And I like to do that with all of the most common side effects, because the other thing is, a lot of these patients are going to read on the internet, read the package insert, talk to friends and family, and find out about the adverse effects that you didn't tell them about. And then they're going to get them anyway. And then they don't have the full story. So I think it's important to educate people about this, even if it does mean you're increasing the chances that they get them. Um, maybe you're going to lessen the amount of people that get adverse effects, but the ones that do, that they tolerate it and push through it and keep taking it and keep working with you and come back and maybe change to a different drug, right? And that's fine. That's what we want. We don't want someone who has an adverse effect to continue taking the medication when there's other treatments that they could take. Okay, so these are all ways that we can kind of play with the placebo nocebo effect. And I just want to talk a little bit about kind of the medication in general, and how just the way it is could give you a placebo effect. All right. So the color can, they've shown that gold is the most effective, followed by silver, followed by any color, and then lastly, white is the least effective. And it's like, man, most meds are white. Why would they even do that? I don't know. Like I would make my pill gold, I think, if I were making a pill, since that's supposedly the most effective. Um, red has actually been shown to have more of an activating placebo effect, and blue a calming effect. And also the shape. An angular shaped pill is more activating, and a curved shaped pill more calming. Angular shaped pills are more effective than curved shaped pills. Taking a medication more often, more effective than less often. Higher doses tend to have more effect than low doses. And we're talking about this is all placebo. Of course, that would be for the chemical of the drug too, but also the placebo goes up with a higher dose. Brand names. If the patient knows they're taking a brand name versus a generic, more likely to have placebo effect. More expensive medications. So the more that they know it costs, or the more that they paid to get it, the more likely it is to give a higher placebo effect. If the drug has a taste to it, maybe a liquid or a chewable of some kind, a worse taste has more placebo effect than a less bad taste. Um, and then more painful treatments. So, say stabbing someone with a needle or something, more painful treatments are more effective. And I am actually credentialed to do auricular acupuncture. I'll talk about it a little bit later in our depression series, if, or maybe anxiety. But it's not painless, but it's not that painful. But it's more painful than taking a pill. So I've seen great results, and maybe it's there's very few side effects to putting these pins in people's ears that fall out, um, and it is a little bit of pain, and that may increase the chances. I'm not sure that I don't know what the actual effect size of this procedure is, but anytime you're doing something that's a little bit more painful, you're getting a little bit more placebo effect. Interesting, capsules more effective than tablets. So capsules are plastic, they have like some sort of powder dots, pellets inside, whereas a tablet's like a hard, you know, if you chewed it, it turns into a powder. And then the route of administration. So a surgical procedure being the most effective, followed by like an IV or IM medication. So intravenous or intramuscular, that's needles, followed by PO, which is oral taken medication. And I mean, I don't know if like, rectally taken might be more effective because that's less pleasurable, or uh, less benign than taking it orally. But yet there was a great placebo study where they were doing these arthroscopies where the orthopedic surgeons go in and they clean out the knee of like debris. And these procedures were thought to be very effective, but somebody got the idea to do a sham surgical procedure, and they actually performed. They put the patient under anesthesia. They went through the motions. What they said, what they were doing. They acted as if they were doing the surgery, in case the patient could actually hear or feel while they were anesthetized. And they actually made a cut on the knee where we're going to put the scope in, and they stitched it up, but they didn't actually put the tools into the knee. Um, and essentially, this kind of sham surgery where the patient believes they got an arthroscopy or whatever they call it. I'm not a surgeon. Um, was basically equally as effective as getting the actual procedure done. And so then it's like an ethical dilemma of like, do we continue doing this thing that's not better than placebo, but like we can't actually do the placebo because we can't charge to do nothing, and we can't like do nothing. um, but yeah, like the more invasive the procedure, or pill or administration of however the treatment they're getting, the higher the placebo effect they're going to get. And so as you can see, a lot goes into this that's just like related to the pill, related to how you give the information. And yeah, I think this is just really really important information, and it's like, how do we harness this? Well, that's what we're going to talk about on part 2, which I'm entitling improving effectiveness of antidepressants. Like, how can you in the way you prescribe and the way you communicate with the patient and the way you interact with the patient that you prescribe this pill to, how can you be one of these providers that gives like the max placebo effect versus like minimal placebo effect? I want to be one of those providers. I wish I had known about this sooner. Somebody needs to study this. Somebody needs to teach a class in this. Everyone needs to learn about this because, I mean, when you're talking about the meds giving such a small placebo and the placebo effect being such a huge range of possibility, um, you could basically be doing something that's not clinically meaningful to like very clinically helpful to patients. And so I'm not sure that I'm the right guy to teach you this, but because I don't think I'm the best at it. However, like I said, I have researched it. I have 9 slides where I go through lots of points, and I'm going to talk about studies that were done, like when you do this kind of thing versus this kind of thing, when you have this kind of patient for this other kind of patient. We're going to talk about it in the way that I like to talk about things, from a scientific, statistical, fact-based method. But we're going to be talking about something that is a little fluffier, and maybe if you're like me and you're a little bit more analytically minded, you can I can teach you how to do this in a way that your analytical mind will be more able to accomplish. Whereas, the folks out there that are already doing this, they're already doing this. They don't need, they'll probably be like, duh, of course you do that. Like, how could you not do that? It's so easy. Well, for us, more logically analytical, introverted folks that are less in touch with those type of things, that are less touchy feely, that are less fluffy, that are less, engaging with others, maybe we need it, and it's going to be something that you can actually do, right? I think I hear, people talk about like how to make friends and influence people, or like how to, do well in an interview. And it's a lot of fluffy stuff. Some of it's going to be fluffy, but some of it's going to be like very black and white. Like, you do this, not this, and you're more likely to get a better effect. And it's something that even if you have a hard time with this, I think you're going to be able to learn from. And for those of you that do this really well, hey, I think there's probably some tidbits in there for you, that some stuff maybe you didn't think about that you might be able to do to enhance what you're already doing well. All right. So I I want to thank you so much for listening to this episode. Like, I know that we didn't go into like anything about the meds and like you're here for meds, but like we're talking about 1.59 effect size versus zero point 0.3. We got to talk about this. And this is something that you can do, and that this is something you do when you prescribe pills. Those that don't prescribe pills can't do this. This is an effect that is much more powerful than the drug, that comes with the drug. And it is so important to know. And I don't think it gets enough press. So thank you so much for listening, tuning in, rating, and I will see you next time.
Can't you see my soul?